This CLDF podcast is supported through an educational grant by W.L. Gore.
Hi, everyone, and welcome to the CLDF podcast. We are at the 6th Liver Connect meeting in sunny San Diego. And the topic we're going to be talking about today is the TIPS procedure and really kind of identifying appropriate candidates and minimizing the risk for our patients. Now, the first area we're going to be tackling is really looking at, how do we identify the right patients for TIPS referral? And so generally, the right patient for a TIPS tends to fall in one of three main categories. Number one, you have patients who are presenting with recurrent or high-risk variceal bleeding. Number two, they're presenting with refractory ascites. And then select cases of what we call portal vein thrombosis or hepatic venous outflow obstruction. Now, when we talk about variceal bleeding, then that needs to be differentiated further into early, salvage, and what we call secondary prophylaxis. So in terms of early or preventative TIPS, which typically is done within 24 to 72 hours of a patient presenting with variceal bleeding, is reserved for high-risk patients. These are typically going to be patients who have a Child-Pugh score C between 10 to 13 or Child-Pugh B with active bleeding at endoscopy. Now, in that group, early TIPS has shown to significantly reduce the risk of rebleeding and improve survival. Then we look at the category of what we call salvage TIPS, and this is typically for our patients who, despite optimal medical and endoscopic therapy, continue to have ongoing bleeding. And so TIPS is essentially used as salvage therapy to stop the bleed. And then the last category is what we call secondary prophylactic TIPS. And this is typically for patients who've recovered from the acute variceal event, but still remain at high risk of a rebleed. So that kind of covers, your variceal bleeding population. Then looking at the second big kind of group in terms of indication. Now, these are your patients who are now, presenting with refractory ascites. And these patients are typically the ones who've failed being on maximum diuretics coupled with sodium restriction and are still requiring, frequent large volume paracentesis. Importantly, there's a lot of emerging data now suggesting that we actually don't need to wait till ascites essentially becomes refractory. Even in patients who have recurrent ascites, whereby they're requiring repeated paracentesis despite optimal medical therapy, there is significant benefit for earlier referral, even potentially preventing further decompensation in terms of the patient coming in with a variceal bleed or what we call spontaneous bacterial peritonitis. Now, the last kind of group of patients that TIPS does really well for are patients who present with portal vein thrombosis. And so in select patients with cirrhosis and portal vein thrombosis who may have, a concurrent other indication for TIPS as well, portal vein recanalization with TIPS can really restore blood flow and even facilitate further liver transplantation. And so there's a significant number of studies that have come out showing that high recanalization rates and improved technical feasibility at transplant significantly improves patients' outcomes. And then lastly, this is looking at a different group of patients, not particularly who have chronic liver disease or cirrhosis, but really patients who are presenting with hepatic venous outflow obstruction, such as those with Budd-Chiari syndrome, whereby you have a prothrombotic or a high thrombotic state, such as a JAK2 mutation, which is resulting in significant portal vein thrombosis. And so in those patients, we typically adopt a stepwise approach whereby, first they're put on anticoagulation, then there's an attempt at what we call angioplasty, and then ultimately TIPS if medical therapy fails. And what we've seen is that when TIPS is done for these patients with Budd-Chiari syndrome, it not just provides durable decompression of the portal vasculature, but significantly also improves transplant-free survival. So with that, then the question becomes, okay, well, what about the frailty index in TIPS, right? So how do we use the MELD 3.0 score and sarcopenia assessments to predict which patients will go on to develop post-TIPS hepatic encephalopathy? And that's a really important question to answer because hepatic encephalopathy can be significantly debilitating for patients and affect morbidity quite a bit. And so once you identify the optimal candidate for a TIPS, the next major question is risk stratification. And risk stratification mainly to identify which patients are at higher risk of developing hepatic encephalopathy. And so this is really where the concept of sarcopenia and frailty becomes very important and has been shown to actually been one of the strongest predictors of post-TIPS encephalopathy. And so the gold standard right now is to use CAT scan-based skeletal muscle index at the L3 vertebra or combined with, bedside tools like the liver frailty index to identify which patients might be most vulnerable. Coupled with that, higher MELD scores above 18, advanced age, hyponatremia, or pre-existing encephalopathy all will increase the risk. And so the key isn't saying, let's not offer these patients a life-saving TIPS procedure, whether that's being used as a bridge or an intermediary to get them to transplant. The question really is, how do we optimize these patients to mitigate their risk or at least minimize their risk of developing hepatic encephalopathy? And that's really where the role of optimizing them from a nutrition standpoint, physical therapy prior to the procedure all come in. Next, we're going to move on to talk a little bit about, we've identified which patients are good for this. Which patients should we absolutely not be offering this to? So essentially, which patients have an absolute contraindication for a TIPS? And so when we talk about absolute contraindications, I'd say the biggest one is heart failure, coupled with severe pulmonary hypertension, because what we're doing with the TIPS is we're essentially increasing venous return and cardiac preload. And so any underlying cardiomyopathy must be carefully assessed. And, if coupled with that, the patient has a mean pulmonary pressure above 45 millimeters of mercury, that becomes a major red flag. Now, other considerations would be if the patient has uncontrolled systemic infection or overt sepsis, or if they have severe refractory hepatic encephalopathy. And the way that we essentially define that is a patient who's already on maximum available medical therapy, such as combination of lactulose, rifaximin, and zinc, and they're still having recurrent either hospitalizations for hepatic encephalopathy or presenting to your clinic repeatedly. And I'd say those are the patients where you should be extremely mindful and reconsider decisions about proceeding with a TIPS. Now, that's not to say, if you're in a life-threatening situation where a patient's presenting with, recurrent variceal bleeding that's just not salvageable, you say no, but it needs to be a multidisciplinary discussion and a shared medical decision with the patient and their family. And then lastly, we're just going to touch a little bit upon the concept, or I would say emerging concept, of using smaller diameter TIPS stents and looking at the data on whether stent size alteration or essentially reduction can help balance pressure reduction with hepatic encephalopathy risk. And so there's emerging work that's happening in this space. And what we've seen is that this may in fact end up being the most important tool we have to balance the effectiveness of the TIPS versus the safety. And so historically, we've used 10 millimeter covered stents. However, there's data consistently now coming out showing that maybe using 8 millimeter stents instead could significantly reduce rates of overt hepatic encephalopathy while still maintaining similar control of bleeding and ascites. And even more interesting is now the use of what we call underdilated 6 to 7 millimeter covered stents, which further reduce risk of encephalopathy without really compromising benefits achieved from portal decompression. Now, these smaller stents, the ones that are about 6 to 7 millimeters, do not self-expand to 10 millimeters, which helps maintain the lower shunt fraction, essentially. And so current guidance is, now supporting the use of these smaller diameter stents, particularly in patients who are more vulnerable for hepatic encephalopathy. And so with that, we come to an end. Thank you so much for listening. And for more information, please don't forget to visit the Chronic Liver Disease website. Thank you.